Hi guys, my name is Niyati and welcome to this Chegg video tutorial. I'm a tutor here on Chegg Tutors and I'm also tutor biology and medicine. And in this video, I'm going to be talking to you about the diagnosis of diabetes insipidus. So if you've seen some of my previous videos on this topic, I've already spoken about what DI is, what the symptoms are and clinical features are. And in this video, I'm going to tell you how to diagnose it. So apart from the clinical features of polyuria, which is increased volume of urine or increased urine output, the urine is also going to be watery and bland. And some of the tests that we can do to diagnose this is urine osmolarity, urine volume, serum osmolarity, and serum sodium. So in DI, what you're going to notice is if you take a sample of urine and you measure the urine osmolarity and the urine sodium, both of these values are going to be very low because the urine is going to be very, very watery. There's going to be a lot of excretion of water in the urine. At the same time, your sodium level, your serum osmolarity is going to be very high, meaning your serum is going to be more concentrated with solute since all the water is being drained out in the urine. So your urine osmolarity and your urine sodium are going to be low. Your serum osmolarity and your serum sodium are going to be high. And the serum sodium, though, is going to be high only when the oral replacement is not enough to keep up with the urine losses. So if the person is just peeing out all this water and not taking in enough water, then his serum sodium concentration is going to go up relatively, and that's a condition that we call hypernatremia. So these are some of the lab investigations that you can do. These are, if you find these findings on your lab report, then you might suspect DI, or rather, if you suspect DI, these are the investigations that you need to order. So now, in order to confirm DI, what we do is we do the water deprivation test. So basically, in this, what is done is that a baseline measurement of the patient's body weight, the urine volume, how much urine the patient is producing, and the urine osmolarity, measuring how concentrated the urine is, as well as you're going to measure the serum osmolarity. I'm sorry, there's a spelling mistake right here. This should be O instead of an I. That stands for serum osmolarity. So after you measure these baseline values, you then go ahead and fluid restrict the patient. You do not let the patient have any intake of water. And then you measure these same values every hour. And if there's a rise in serum osmolarity and serum sodium, then that is going to tell you that this could be DI. And the diagnosis of DI, diabetes insipidus, is confirmed when the serum osmolarity becomes 300 milliosmoles per kilogram or more, meaning the serum is becoming more and more concentrated. And when the urine osmolarity falls less than 600 milliosmoles per kilogram or less, which means that the urine is becoming more and more dilute. So the higher the osmolarity means the more concentrated a solution is. The lower the osmolarity means that the more watery it is. So in DI, you're going to have a more watery urine, so less than 600 osmolarity. And you're going to have a very concentrated serum, so more than 300 osmolarity, because 300 is about the normal range of your serum osmolarity. So after this, what you do is, now that you've diagnosed DI, you have to figure out whether this is central DI or nephrogenic DI. So to differentiate between the two, you have to look at the response to vasopressin. So this is basically external exogenous ADH that is administered to the patient. It's also called DDAVP. So in a patient with central DI, when you administer exogenous ADH, their urine osmolarity is going to rise by at least 50% after the DDAVP is administered. So, and the reason for this is because, as we know, in central DI, the issue is that there's no ADH produced or not enough ADH produced by the pituitary gland. So in these patients, when you administer ADH from outside, now their DI is going to kind of normalize. So in these patients, now that this ADH is acting from the outside, now they're going to try to conserve water in urine all of a sudden. And now that's why their urine osmolarity is going to rise and the urine is going to become more concentrated. But once you've diagnosed DI in a patient, and if it is nephrogenic DI, then even if you administer ADH from the outside, So even after exogenous administration of DDAVP, there's going to be no change, no rise in the urine osmolarity, because as we know, the main problem in nephrogenic DI is that there's reduced response of the ADH in the kidneys. So nothing is going to happen. So this is how you diagnose DI in the first place, by water deprivation test. And then to differentiate what type of DI it is, whether it's nephrogenic or central, then you do the response to DDAVP. Going on, there's just this little graph right here that I've made for you to kind of help you get an idea of what's going on in DI versus normal. So in a normal person, when you are water deprived, or if the kidneys sense a relative increase in sodium chloride concentration, they're going to try to conserve as much water as they can, because it's going to sound to the kidneys like you are losing fluid or that you are losing blood, and they're going to try to maintain the volume and maintain plasma osmolarity by retaining water. So in a normal person, as the plasma osmolarity increases, you can see on the x-axis right here, as you go towards the right with an increasing plasma osmolarity, your urine volume is falling, which means that the more and more dehydrated you get, the less and less urine you're going to produce, which is normal because you're going to try to retain all that water. So in the pink graph right here, this is the change that would occur in urine volume with change in plasma osmolarity in a normal person. Now looking at this blue line right here, this is what happens in a person with DI. So in DI, no matter how concentrated your plasma is, with increasing plasma osmolarity going in this direction, your urine volume is still remaining the same. It's not going down, which means that in a person with DI, even if they are dehydrated, they're still making the same amount of urine as they would when they're not dehydrated. And that's not good, because when you're dehydrated, or when your kidneys are sensing a loss of volume or a loss of effective arterial circulation or dehydration, they should normally try to retain water, and this is done by the effect of ADH. But in patients with DI, as we saw after the water deprivation test, they still go on to produce a lot of dilute urine. The urine osmolarity is less than 600, which is very, very dilute. So this is what this graph is showing. So no matter how much you increase the plasma osmolarity is going on increasing, but your urine volume is still remaining the same. So that is what happens in a person with DI. So hopefully, I hope this video helped you, helped to clarify some things about how DI is diagnosed and the differences between the two types. In my next video, I'm going to talk about how you treat diabetes insipidus. So I'll see you in another video. I hope you enjoyed this video. The link to my tutor profile is down below, so you can feel free to ask me questions on there if you want. And see you in another video. Bye. Have a nice day.